departamento departamento cardiovascular del Hospital Misión de Ciudad de Madras en la India. Nos va a platicar de las estrategias para tratar de disminuir la mortalidad en el choque cardiogénico. Doctora Gui, por favor.
Can I have my slides, please? Okay, so I think there's some bit of overlap between Paul's and my talk, and I will stick to my experience at the hospital and how we've tried to get a handle on cardiogenic shock. So we've gone through this whole issue, and this is one last frontier we have to treat in myocardial infarction and many of the patients. So cardiogenic shock seems to be still a problem. The mortality is 70 to 80% with conservative management. The incidence has come down in Europe and the United States because of early access and early interventions. But it continues in developing nations at 5 to 10%. It still is about 6% to 8% in our hospital over the last 15 years. Thrombolytic therapy is less effective but can be used if there is no option, and early mechanical revascularization improves survival. And in the SHOCK trial, early revascularization resulted in 132 lives saved at 1 year per 1,000 patients as compared to medical therapy. Now, as the previous speaker said, it's important to differentiate mechanical causes of shock, and these are known: ventricular septal rupture, tamponades, acute severe mitral regurgitation, and right ventricular shock. But what we're concentrating is on the last group, and that is predominant left ventricular failure, which is about 75% of the shock patients. So for reperfusion, we should understand that early reperfusion has improved outcomes in shock. Thrombolysis is not so great. Mechanical revascularization causes complete and sustained reperfusion. And PCI is the most frequent port of revascularization chosen. And despite all the advances, the mortality continues to be close to about 50%. And if you look at the NCDR registry of the United States, you will see in the last few years the shock outcome mortality has increased. And the problem is not because of therapies, it's possibly because of the risk of the patients. You have more elderly patients, you have re-intervened patients, you have patients with chronic kidney disease and lung problems. And the moment they get into MI, their outcomes are poor. So we started looking at our data of shock, and this is a single center experience of a large tertiary unit. And we looked at shock over a period of about 7 years in the first group and then 10 years after, and saw whether the outcomes differed and what we could do to, in a middle-income country or a low-income country, how to reduce the amount of shock and complications because of this. And this was the first aim, to predict the outcomes and to know what to do when patients come with shock. So this is the first data, about 6 years, PCI primary 2,870, 235 primary, shock 41, and we looked at all their data. And the diagnosis of MR was standard. I'm not going through that. And shock, by definition, is important that we have to define it as systolic blood pressure of less than 90 millimeters for at least 30 minutes, or the need for supportive measures. We should have end-organ hypoperfusion with cool extremities or urinary of less than 30 ml and a heart rate. It should not be hypovolic in bradycardia, and we should in general rule out mechanical causes of shock. So these were the patients who were included, which is basically patients with left ventricular failure in this group, which was studied in the hospital. Now, if you look at this whole data, which is basically all PCI patients who had shock in all the clinical parameters on the left, survivors and non-survivors as two groups, and we looked at the analysis of them. There were two predictors which came in very quickly. One is transfer admission and the other was CPR. So people who were transferred late, especially from one hospital to the other, or who had CPR were technically going to be a non-survivor in the first phase of the study. This was the time between 2007 and 2001. The second issue which came through was their pre-TIMI flows. If their pre-TIMI flows were poor and their post-TIMI flows were poor, those patients did not survive. So it's important that you achieve TIMI 3, and if not TIMI 3, at least TIMI 2, to get the patients out of the hospital. The second issue is that if you have epicardial stenosis of more than 50% plus a TIMI flow which is low, less than 3, you're likely to have an unsuccessful PCI and hence a bad event. So clearly what it tells you is that you need to have a successful intervention with good TIMI flows and good myocardial perfusion for the patient to be a survivor. Finally, if you looked at the first era of our shock patients, and you looked at the shock trial data, which is almost at similar times, our data was for 40 patients, shock trial was for 82 patients, age was about 7 years younger. But you can see, just like in Mexico, the diabetic patients are higher. The mean time from MI to shock, and that is late presentation to hospitals, was high. And the mean time from revascularization from MI was also high. And that's because you landed up in a smaller hospital. By the time they got the ER, shifted in an ambulance, and then came, all this landed up in Versa times and Versa times revascularization. And this led to basically poor TIMI flows. TIMI 3 flow, you can see, was only 49% in our data, though the intra-aortic balloon pump in that era was 100% of patients. Stents were 90% and 2B3A receptor blocker was 85%, but our 30-day survival was 45%. So less than half of the patients survived despite we trying to do what we could in that era with all what we could do. So the 1 year survival was also lower, which is about 40% as compared to the shock data. So in the phase 1 study of AMI with shock, even with whatever best available treatment at that time was available, the mortality rate was high. The preserving ischemic myocardium PCI reduces the in-hospital mortality. Once the patient survives in hospital, they maintain their survival to 1 year. The establishment of TIMI 3 flow is of paramount importance. We thought at that point of time mortality could be due to the longer delay between MI and shock onset and PCI, and transfer admissions and main contributors to delay, and CPR and kidney issues on admission clearly were bad prognostic outcomes. Early stratification, better reference systems, optimal use of ejective terraces and assisted eyes was supposed to be thought could improve the survival. So what happened in the phase 2? That's another 10 years, 10,000 PCIs, PCI with shock was 73. And we again looked at the data. And what we again found, if you looked at all patients 73, survivors 35, non-survivors 38, you can see that there are some univariate and transfer admissions at this point of time came down. You can see transfer admissions were no more an issue because by the time we had the system of care and people realized the moment they were shocked, they were shifted to a tertiary center. The second issue was the heart rates were much higher in the non-survivors as compared to the survivors, and that is tachycardia is a real sign of impending shock and poor prognosis. The systolic blood pressure was lower in the patients who were non-survivors as compared to survivors. The ejection fraction was poorer and the EFs were poorer. What about CPR? Continued to be a risk factor for the non-survivor. Inotrope and vasotrope use, yes. Intra-aortic balloon pump, you can see in the survivors the use of intra-aortic balloon pump was only 37%. So basically we learned that IRBP is not to be used in most patients, and patients who had borderline hemodynamics who improved after revascularization didn't get the IRBP. But in the non-survivors, still the IRBP uses was pretty high, 73%. And that could say that the patients who were sicker were the ones which mandated an IRBP and therefore they died. And the mean IRBP duration was higher in the survivors as compared to the non-survivors, showing outcome improvement. Renal dysfunction was borderline, but anterior volamine was a surrogate. Again, what continued was that the type of disease, both in stage 1 and stage 2, did not affect the mortality. It did not affect whether you had left main or triple vessel disease. But clearly the post-TIMI flows and the PCI success continue to be a predictor of poor mortality. So basically, if you had poor PCI-TIMI flows at the end of the procedure, patients continue to die. If you looked at the phase 1 and phase 2 and looked at the analysis between both, we found that the systolic blood pressures were a little better in the phase 2. The mean LVEF was a little better in phase 2, that is the later period of time when this was assessed. The thrombolytic use came down, the multivessel disease was the same, intra-aortic balloon pump usage came down, the 2B3A receptor came down, CBS came down, transfer admissions came down, mechanical ventilations came down. But unfortunately, despite all these things, the mortality continued to be 52%. So clearly, we tried to fix a few of the things, but continued in the single tertiary experience that half the patients still died. And I think clearly, basically the systems of care still needed much more improvement. The patients who were sicker were brought into the hospital and they died continuing despite the best usage of therapies. Impella is just in India, but it's too expensive, and we don't use Impella because it's too expensive. The data is in some few studies, yes, some few studies, no. ECMO is used, but the mortality, at least in AMI shock, is close to 80%, and you clearly have to look at the limb when you treat these patients, and you need to have a real perfusion group with you. And I think the VAD is one option which we could use to fix before the transplant. Myocardial protection drugs have been studied, unfortunately have not been shown to have any improvement in outcomes in patients who come to shock. So conclusion was that mortality remained high in cardiogenic shock, and it remains to 50% even with current contemporary revascularization. Achieving infarct-related attack is the main determinant, and quick revascularization is the most. Better mechanical supports, maybe, maybe not. I'm not so convinced at this point of time. We need to have more information and more data with Impella VAD and ECMO, and myocardial is not. Let me show you some case profiles of patients. A couple of angiograms before I close. This is a typical patient. Came in just outside the hospital ambulance, had a cardiac arrest, resident coded, before went to the ER, prolonged resuscitation, 45 minutes, recurrent VTBF, 30 shocks, mechanically ventilated, intra-aortic balloon pump inserted, high inotrope, no mechanical complications, severe LV dysfunction. We didn't check the neurological status. Patient went to the cath lab straight away for PCI, and patient had, you can see, very bad disease in the LAD. The culprit was obviously left ventricle descending. There was disease in all three vessels, diabetic, typical vessels. And patient had a very quick procedure, rehabilitation, and a stent implanted. And the most important thing here is to get your culprit ready. The moment the culprit is ready and your pressures come up with the intra-aortic balloon pump, it's important to back out and not use too much of procedures. You can see the diffuseness of the disease in the distal LAD, but that doesn't matter. As long as the pressures come up and your pump pressures are okay, you stop. Because the more you inject dye, the more you're going to harm the myocardium and the kidneys, and the more you're going to get into trouble. The patient regains consciousness on the same evening, extubated day 3, IVP removed day 4, discharged on say 7. Neurological status after 30 days was pretty good. But this is not common. I have to say that outside hospital cardiac arrests don't survive that much, and it was just fortunate that the patient arrested just before he entered the ER in shock. There's a second gentleman, which I'm not sure is common in Mexico. It's a 27-year-old gentleman, and this is in India you don't have cocaine and those sort of abuse, and these patients are typically smokers, very young people who are not very rich people, they are poor people, and he had a failed thrombolysis after an atrial MI, and very quickly shifted, but you can see that the hemodynamics is not good. He was in Phillips class 4 with shock and with a pulse rate of 110 per minute, anterior territory, severe dysfunction, no mechanical, electively intubated and started on inotropes, taken for rescue PCI, shock. And you can see clearly, and this is something which is very common, these patients will have single disease. There's a single lesion creating the problem. And this is typically what we call this plaque erosion, not rupture. Here the patient had a simultaneous move to the cath lab even before he didn't enter the ER at all. had an intra-aortic balloon pump simultaneously from the left femoral artery and a catheterization from the right groin. And you can see that the left vein is just completely occluded. And this patient had, what we now do is an infusion of eptifibatide, thrombosuction very quickly with an export catheter. We don't stent these patients without having a look, especially these young people, because they don't have any blood most of the time. And we had a look at this is thrombosuction very quickly with a large thrombus 7 French and intraperitoneal balloon pump in place. And what you get is a reasonable flow, and you can see that that left main has a lesion, but we tend to hold back the stent because in a shock patient, you put a stent, you push a lot of stuff in, and that will create more problems in the myocardium. Post-procedure was switched to CC with support, extubated, hemodynamics improved, and we always check these patients just before discharge to see that everything is okay. And this is how the angiogram looks. And there is some lesion in the LAD, in the left main, but it's not pro-limiting, and you can leave these patients alone. And these patients have been followed up, and this is a paper we published in Heart Lung Circulation of just thrombus expiration, no stent, in young patients with left main occlusions in shock. So these are unusual presentations, and we don't like shock, we don't like to put stents in such patients. This was already talked about the way you put temporary mechanical supports, and these are clear-cut for patients who are. I think this is a very simple chart which tells you cardiogenic shock. You just need to do your clinicals, you need to do an echo, EKG, a blood gas, serum lactate. You need to assess, and you have to put in the pulmonary artery catheter to be sure you're not having any problem either of flow or filling. And if you have still refractory shock and organ failure, it's important to intervene quick. And we have learned very quickly that get the heart team approach, get in the intra-aortic balloon pump before patients deteriorate, and impellers may be better in giving more support, and tandem hearts are better, but I think these are unavailable for us and too expensive for us to do, and we don't use this at all. But I think we should not forget the risk of limb ischemia and hemolysis. And remember, when you put a VA ECMO, it's a very important thing to understand that the ECMO increases left ventricular end-diastolic pressure. So you need to put in an intra-aortic balloon pump at times to decrease the end-diastolic pressure when you are in ECMO, otherwise you may have a filling problem. So I'm not going to go through it, but though the evidence for intra-aortic balloon pump, just like the previous speaker said, is that there was no difference in survival in many of the trials, we in our hospital put our intra-aortic balloon pumps very early and very quickly in many patients who we think are in impending shock. And in our hospital, more than 5 pumps are on patients every day in the hospital. I think the impeller was already, there's some studies showing the effectiveness of the impeller over IBP, the 30-day survival, but against the recent trials don't show very much difference in these two outcomes. I think ECMO is important, but in the scenario of epitomized shock, the outcomes are poor. I think it's more good for a patient who's coming off the cardiac surgery or for a respiratory problem that patients do well with an ECMO. So I think the 5 important lessons of in shock that we've learned over the last 15 years is that rapid clinical and hemodynamic assessment of shock should be performed, early revascularization of the culprit is to be performed, early insertion of intra-aortic balloon pump and appropriate hemodynamic support if you can get an impeller in affordable scenarios is mandatory. But if you put this in too late, I think the horse is already bolted, and I think your mortality is going to be huge. I think it's important to especially have a cardiac surgeon with you, because many of these patients post-PCI get into shock, and many of them develop either a VSR or a mitral regurgitation after percutaneous intervention. And if you don't keep your eyes and watch on these clinical features, you'll suddenly see a patient decompromising, and these are usually due to mechanical issues. So it's important that you have perfusionists and intensivists to improve outcomes, especially when you're putting ECMOs. I think despite all the progress in the treatment of shock, mortality remains 50%, and the best way to treat shock in one way is to prevent it by coming in early for the recognition of MI and prompt stabilization. But unfortunately, the risk factor profile of patients are going to get worse as you get better in the treatment of PCI for AMI, and you're going to have more elderly people with more comorbidities, more CKD, more lung disease, and multiple interventions, who unfortunately will have a poor prognosis whether they have STL patient of mine or non-STL patient of mine. Thank you very much.